Thank you all for coming today, and a huge thank you to Dr. Susan Bergman and Melissa Agrimanakis for joining us, for lending your knowledge, your expertise, your time on this incredibly important topic in the spinal cord injury community. This is being recorded, so it will be on our YouTube page. And just going to ask if we could stay on mute while the speakers are speaking, if you don't mind. If we can just hold questions until the end of the presentations. Also, just want to ask, we welcome any questions that you have, but just a reminder to keep your questions a little bit broad. Both Melissa and Dr. Sue won't be able to answer anything very specific about maybe something, a specific issue that you're having right now. That's something that, we should probably be taken offline. So again, just to kind of keep it a little bit more broad. And I think we're just going to get started, and we're going to start with Dr. Sue.
Thanks, everybody. Good morning, and thanks for coming. We're going to be talking about how to keep your skin healthy after an SCI. People with SCI, as you know, face a particular risk of developing skin ulcers, and many aren't really sure how to cope with a wound. So today's goal is to learn what pressure ulcers are, why they're so dangerous, how to recognize the threat level of a given wound and respond appropriately. I'll review what skin does, how wounds happen, and why staging a wound is key to selecting the right treatment. Melissa will discuss prevention strategies, especially positioning tools, and then we'll both take your questions. Next slide, Melissa, please. Thank you. Okay, in preparing this talk, I found a terrific online resource for staying healthy after SCI, probably the best I've ever seen. And if you haven't seen it already, I really suggest downloading it. It's called the SCI Health Toolkit, and it's available on the App Store and Google Play. It has modules on mental health, bowel, bladder, skin, pain, and autonomic dysreflexia. It's a product of the SCI Wellness Project from the University of Sydney, Royal Rehab, the Agency for Clinical Innovation, and the Northern Sydney Local Health District, which are all sponsored by the Australian government. And the creators have made it fully available for people with SCI, and it's especially useful for people with new injuries. Next slide, please. So some things to remember about SCI. With SCI, the more you know about how your body works, the easier it is to construct your routines and your environment around what you need to stay healthy. And success after SCI lies in taking advantage of what works in your body to help what doesn't. And the problem, of course, with SCI is failure to communicate. The spinal cord's job is to relay messages back and forth between the brain and the different systems in your body. If the cord is damaged, the messages don't get through, so parts of the body don't know what to do. They're on their own. So learning to read your body's new signals helps you to intervene early and head danger off at the pass. Next slide, please. Many vital functions run in the background and they're reacting to information that's transmitted to the brain by the spinal cord. The brain transmits instructions back, again carried by the spinal cord, and this feedback loop is what lets our bodies maintain an overall balance. Without accurate information in real time, the different parts of the system are out of sync, with each part doing its own thing. If an individual piece of the system doesn't receive instructions, it either shuts down or does whatever it thinks is correct. So the timing might be off, or the action taken might be counterproductive, and the result is chaos. And that can trigger symptoms like increased spasticity, neuropathic pain, and autonomic dysreflexia. Next slide, please. So learning how the parts of your body work in concert and putting the pieces together will help you get around your injury. An analogy is a jet plane that has a computerized autopilot system that's running. A human pilot can use manual instruments to fly a plane if the computerized autopilot fails. It's not easy, but it can be done if the pilot understands how the instrument works and how the plane works. Then the pilot can put them together to land the plane safely. For people who survive a spinal cord injury, the parts of the system are mostly intact. They just can't understand each other. So the person with an SCI needs to consider everything that was on autopilot and establish new and specific routines to make sure that vital functions continue. Even if the result isn't exactly like it was before, it's good enough to support a good life. Next slide, please. So how do all of these things relate to skin? Skin is alive and dynamic. It's there to protect you, and it's a lot more complicated than it looks. It has some built-in repair mechanisms, but to repair itself, your skin needs good blood flow and plenty of nutrients to use as building blocks. And of all those building blocks, protein is the most important. There are some things that you can do to make your skin more resilient so that it can resist breakdown and help it to heal faster. Next slide, please. You can drink plenty of water, eat foods that are rich in lean protein, vitamins, and minerals, change position often, use pressure relief surfaces, both on your chair and your beds, liberally. Make sure to select clothes and equipment that fit properly and allow the right balance between support and flexibility. Check your skin frequently, and you're looking for color changes, blistering, or exposed deep tissue. And mirrors help because people can't see their backsides on their own. You want to pay attention to pressure relief and set a schedule where you change position every 20 to 30 minutes. And Melissa's going to talk in a lot more detail on this. And you want to avoid prolonged exposure to urine and stool, and find some peer support and ask questions. And there are lots of resources, lots of people who've been through it, and there are medical providers and experienced PCAs who can help. Next slide, please. So why do we have skin? Skin acts as the first physical barrier to dangers in the outside world. It cushions the body, and it activates the immune system if necessary. It regulates body temperature by using sweat glands, blood flow, and insulation. And nerve endings inside the skin keep the brain aware of temperature, pressure, pain, and other sensations. And it absorbs UV light and helps produce vitamin D. And it helps with fluid balance. Next, please. Okay, so how does it do that? Well, skin has lots of layers. It has 3 distinct layers: the epidermis, which is what you see on the outside, the dermis, and then the hypodermis. And each layer contains distinct structures that carry out the skin's different functions. The epidermis has cells that absorb light, provide pigment, help regulate calcium, and first-line immune cells and receptors for light touch. The dermis has sweat glands, hair follicles, and associated muscles, sensory neurons, and blood vessels. And the hypodermis contains additional sensory nerve cells, blood vessels, and insulating fat. We need to remember that there are also layers under the skin, including muscles, tendons, connective tissue, and bone. It's important to remember that the skin's function are easily affected by wounds, depending on how deeply they extend. Next slide, please. So the nerve endings in skin provide real-time feedback to the brain. And why is that so important? It's because unpleasant sensations act as an early warning system to tell us that we're in danger and we need to change something. In the case of skin, the sensation of being in one position for too long tells us we need to move. Neurotypical people get uncomfortable if they spend too much time in one position, so they fidget or they stand up or move around. and the discomfort causes the person to make some sort of a change. Next slide, please. After SCI, the feedback from the skin is either incomplete or absent altogether. And again, without accurate feedback, the brain doesn't realize that you've been in one position for too long. And without that kind of feedback, you won't realize it. So the risk of injury increases. Not only that, the loss of movement and flexibility will limit the ability to change position to relieve pressure. However, some signals may get through by taking an alternate route through the autonomic fight or flight system, which usually remains intact. So you may feel some increased spasticity, neuropathic pain, lightheadedness, generally ickiness, or full-blown autonomic dysreflexia if your injury is above T6. And these symptoms become your early warning system. So if you feel them, there's always a reason. And if your bowels and bladder are on target, check for a pressure sore, among other things. Next slide, please. So what are the things that cause skin to break down? Well, pressure is probably the one that we think of most, and that is a continuous force that's exerted on or against an object by something in contact with it. And excess pressure, especially over bony prominences, damages the skin by cutting off blood flow. It takes very little pressure to cut off circulation to small blood vessels. Shearing and traction are something that happen pretty frequently, but we don't think about it. And shearing and traction means structural tearing forces moving in opposite directions and applied to body tissues. And finally, friction, the resistance that one object encounters while moving over another, and it can slow you down, but it can also crack and tear skin. So how much force does it take to break the skin? Not very much. Consider the glasses test. You take a pair of glasses in your hand and very slowly bring it down onto one of your knuckles until the skin changes color. And if you realize how much pressure that is, and then kind of figure what that would be like for your whole body, you get an idea of how this can happen. If the circulation is cut off for more than 2 hours, the tissue that's supplied by the set of capillaries that are cut off will be starved of oxygen and die. The dead tissues become necrotic and start to decompose, attracting bacteria, which can destroy nearby tissues and can also burrow into deeper layers, affecting their ability to do their jobs. Next slide, please. Okay, so skin breakdown may not look too serious at first, especially if they're the more superficial ones. It would seem also like pressure and shearing injuries would only involve the skin, the first 3 layers, but we have to consider what lies under the skin: muscle, tendon, and bone. If the force we put on tissue is very great or lasts for a very long time, the tissue dies, and the dead tissue tends to rot over time. So you have to think about the severity of the sore depends how deeply the dead tissue extends. And it's sort of like an iceberg. What you see on the surface is literally just the tip. Realize that the damage might go a lot deeper than it would seem. And it may take imaging studies to really see the full extent of a wound. That's especially true if there's any evidence of tunneling or undermining. And the evidence that you might see is a pinhole opening. It's like a sore within a sore. And that's the entry to a literal tunnel that's invading nearby tissues. And it may cause a very indolent infection, sort of like, a fire that just has, hot embers. But it can flare up periodically and cause the wound to break down over and over again, even if it seems to be healing. So next slide, please. Okay, so you want to avoid pressure over bony prominences in bed or sitting. A combination low air loss and alternating pressure mattress is your best bet. It gets complicated getting funding, but there are lots of different ways to accomplish it. Your wheelchair has to fit properly, and it has to provide good back support and good seat support. If you have any spine curvatures or you have any differences in the height of the SCI, you might end up with something called a pelvic obliquity, which means instead of being straight, you're going to have one side much shorter than the other, and the other side is going to be forced upwards. So it comes at an angle. If you're going to use splints, you want to be very careful and make sure that they fit. And if you get new equipment, you want to ease into it slowly and check your skin frequently. If it looks like it's causing a pressure area, stop using it and tell your provider. You want to be vigilant so you can keep the problem under control. Even superficial ulcers can take a little longer to heal than you'd expect. You want to eliminate pressure on vulnerable areas, heels, ankles, back of your head, ischiae, sacrum. You want to use the best transfer techniques that you can. And if you're tired, either get help or use a sliding board. Next slide, please. If you get a sore, try to find what caused it and correct it. So for example, if it's a transfer, from the shower to your chair, and your skin sticks a little bit to the either the transfer board or the shower branch, there is equipment that can relieve that pressure. If the ulcer is over a weight-bearing area, or if you can see that it's not blanching, you may need to go to bed rest for a few days. You want to try to relieve pressure from the area, and if possible, the area should float freely. You want to keep the area as clean and dry as possible, and inspect your skin at least twice a day to make sure that the ulcer is not getting worse. You want to attend to nutrition and hydration. You want to make sure that you take in enough calories in the form of lean protein. Your body needs fuel to heal, and if the ulcer is deep, you may need to consider using a protein supplement. You want to eat a diet high in minerals, lean protein, and vitamins. Zinc, iron, vitamin C and vitamin A will play a big role in the healing process. And finally, you want to drink water to remain hydrated. Next slide, please. So staging a pressure ulcer accurately is really important because the treatments and the prognosis depend on what stage ulcer you're dealing with. So with the stage 1, the skin isn't broken, but it looks inflamed. In stage 2 rather, the skin is broken through the epidermis and down into the dermis. This stage can heal on its own, but it usually needs some sort of debridement to make sure that dead tissue is taken away and strict pressure relief. With a stage 3, the ulcer extends through the hypodermis, and that includes the subcutaneous fat, but it hasn't yet penetrated the muscle. And it looks like a crater. This is where a wound vac might be very helpful. A stage 4 ulcer extends to muscle and probably involves the bone as well. And it will likely have undermining where underneath you can feel that there's tissue that's inflamed, or even those sinus tracts that we talked about, the tunnels. Next slide, please. So stage 1 and 2s will generally heal with topical preparations and different dressings. It would take a very long time to go through each type of dressing separately, so I'm just going to talk about generalities. Some of the topical preparations will help to debride the wounds, get rid of the dead tissue, and encourage the growth of healthy tissue that comes from the bottom up. Some of the common preparations include silver nitrate, manuka honey, collagenase, Dakin solution, which is diluted bleach, and also normal saline, and that's kind of the classic wet to dry dressings. And the way they work is that when you change the dressings, you pull up a layer of tissue. You don't want to, you want to make sure that you're not pulling up a lot of healthy tissue. Gauze is probably best for infected wounds. Hydrocolloids, they're like Duoderm. They encourage debridement, but they're not good for infected wounds. Some of the transparent films, like Tegaderm, stage 1 or 2 without drainage. Alginates are derived from seaweed, and they need to be covered with a secondary dressing, and they dry the skin out. So you don't want, or they dry the wound out. You don't want to use if there's bone or tendon exposed. And mostly it's composites, combination of some sort of dressing that retains moisture and gauze. And there are a whole bunch of others that are out on the market, including dressings that contain silver or other antimicrobials, charcoal dressings, and synthetic dressings. Next slide, please. So stage 1, again, the skin is broken, but it doesn't turn pale when you press it. So you want to keep the affected area clean and dry, but mostly get the pressure off. This stage, fortunately, can heal quickly, usually within a few days, but you got to carefully watch it to make sure that it isn't progressing, getting bigger or getting deeper. Next slide, please. Stage 2, the sore has broken through the top layer, the dermis, and extends in the epidermis rather, and extends into the dermis. It looks kind of like a crater, and it may have some clear fluid or even pus at the base. You want to clean, rinse, irrigate either with sterile water or normal saline, and cover with a secondary dressing to keep it clean. And then finally, take the pressure off and monitor it to make sure that it's not getting deeper, getting worse. Next slide. So when do you seek help? Stage 1 ulcers will probably heal in a few days as long as you got the pressure off the area and it's clean. Stage 2 are more complicated, and managing them depends on how big they are, how deep they are, and whether or not they have drainage. The skin's broken, it can bleed or leak thin, clear, or yellow tinged fluid. So usually you deal with those by using normal saline or Dakins to clean the wound and cover it with a sterile dressing. And the choice of dressing depends on how deep the wound is and how much drainage there is. Next slide. Stage 3s. These wounds penetrate the subcutaneous layer, but they're not yet into the muscle. These wounds can sometimes heal without surgery, but the healing is very slow and can take months. Vacuum-assisted closure pumps and sometimes hyperbaric oxygen can help speed healing. The vac pumps are especially helpful. Stage 3 ulcers are at very high risk for progression to stage 4. And I saw a question on the chat. Dakin's solution is diluted bleach, essentially. Next slide, please. The red flag symptoms to watch for are, first is delayed wound healing. If it takes a year or more for things to heal, there's probably something more going on under the surface than it would seem. The wound sometimes will seem to heal and then it breaks down, and that happens over and over. Or if you can see pinhole openings in the wound bed, that's always a sign of a deeper infection. And we need to suspect that there are abscess formation or even osteomyelitis, an infection of the bone, if you see these. Next slide, please. Stage 4. These extend into the muscle and often into the bone. This kind of ulcer will not heal on its own and has to be closed surgically. And what they usually do is something called a myocutaneous flap procedure, where they rotate some nearby tissue that has muscle and blood supply, and they try to cover the defect. Infected or necrotic tissue is removed, including bone, and the defect gets closed with the flap. Next slide, please. And typically people will spend like 3 weeks on a clinitron bed, which is sort of like an air hockey bed. There's silica beads or sand, and a current of air kind of makes it weightless. It's great for the skin, less great for exercise or mental health. It can really be pretty difficult to tolerate, but it's a limited period of time, and you know that it's going to heal. Once the flap heals, it's time to remobilize. And the sitting protocols usually start with 15-minute trials once a day and skin checks before and after, and you increase it from there as you tolerate it. The process is very slow. It can't be rushed. And another piece that I think Melissa will talk more about is that the chair and the cushion needs to be modified and prepared in advance. So they know for sure, you know for sure, that it fits and that whatever caused the previous ulcer has been fixed. If there's large amounts of infected bone that need to be removed, you end up with that angle that we talked about at the pelvis. Your hips are not straight and even. So you might need a cushion that's at different heights in different places to correct the imbalance. Next slide, please. And that's something PT can really be helpful with. So an ounce of prevention is always worth a pound of cure. So you want to, again, make sure your wheelchair fits properly, that you've got the right cushion. Pressure mapping can help with choosing the right cushion. And you want to establish a routine of pressure relief maneuvers where you change your position every 20 minutes or so. And what you do depends on your level of injury, your overall flexibility, and what position you're in. So for best results, you want to do pressure relief maneuvers, even if your cushion or your mattress is taking away most of the pressure. Next slide, please. Okay, so your pressure relief techniques in a manual wheelchair, you can do wheelchair push-ups. If you have arm and shoulder strength, you can push your body up, hold it for a little bit, and then come down. You can hook your arm around the push handle and pull upward. In a power wheelchair, you can use the control panel to tilt or recline. You can lean or twist to the side if you have the movement, or ask another person to help with repositioning. Next slide, please. What else can you do? You've heard this before. Hydrate, hydrate, hydrate. Balanced diet with lean protein, multivitamins. Keep your skin clean and dry. Try to avoid any sources of friction, cracking, or tearing. Check your skin using a mirror. And you can consider using a barrier cream. Sometimes that's helpful, sometimes not so much, depending on whether you're looking at an area that's very moist and dark or whether you're looking at a drier area. Positioning is your key. In bed, you want to turn every 2 or 3 hours, or you might have an alternating pressure mattress that turns you for you. Next slide, please. Okay, so the conclusion take-home messages. Pressure sores can cause a lot of grief. An ounce of prevention is worth a pound of cure, but there are cures that can be pulled out of the bag of tricks to make things better. Proper positioning, timed pressure relief maneuvers, weight-supported seat cushions, backrests, mattresses, balanced diet, good hydration, and attention to details. Don't overlook things you can control. If your wound is taking too long to heal, talk to your providers and advocate for additional studies to make sure that you don't have a deep abscess or even osteomyelitis. That's it for my part of the presentation.
Okay. Thank you so much, Dr. Sue. Appreciate that. All right, we're going to move to Melissa now. Melissa, are you all set to? And again, go ahead and put questions in the chat if you have something that you want as a placeholder. We can get to them.
Hello, everyone. Thank you for having me today. I know a lot of faces here, which is really exciting. And you all know how much I love to talk about pressure injuries and wounds. So again, thank you for having me. I'm going to talk about the more physical therapy, occupational therapy considerations and aspects of when you do have a pressure injury and how we try and prevent pressure injuries. So my goals of my part of the presentation are just for everyone to understand and really have it ingrained in you how often you should do pressure relief. It is different in a power wheelchair versus a manual wheelchair. So make sure that's in your brain by the end of my presentation. Understanding how therapy, PT, OT, speech can help improve wound healing, and understanding mattresses that you can get for home and seating surfaces that can help prevent wounds. So I know this has already been mentioned, but it doesn't hurt to mention it again. Areas at risk for pressure injuries when you're in bed are any bony areas that the bed surfaces touches. So the ones that I have listed here are the most common. So just be aware of where you do have normal sensation and where you don't have normal sensation. And any body part where you don't have normal sensation is at a very high risk for breakdown. And same thing in a wheelchair. Obviously, the areas are different because you're in a different position, but it's the same idea. If you have normal sensation in an area, much less likely to break down because you'll feel it and it will hurt, versus areas where you don't have normal sensation, more likely to break down because you can't feel that initial pain sensation. So in a wheelchair, pay attention to your tailbone, shoulder blades, back of the knees, your feet, your heels, and then I call them your squishy issues, which are your sit bones. So pressure relief should be performed every 15 to 20 minutes. In a power wheelchair, you're going to tilt, not recline. Tilt. They're two different things. You want to tilt back for at least 5 minutes and you want to stay fully tilted. So I know some people don't like to tilt all the way back because it feels like you're toppling out of your chair, but the wheelchairs aren't meant to hold your weight. They will not topple over backwards unless you're on like a ramp or something crazy like that. So please tilt back fully for 5 minutes. And like I said before, just reiterating, tilt and recline are not the same thing. So if you look at the picture on the bottom here, you see a gentleman in a power wheelchair, and then you see pressure mapping underneath him. So in the first picture, he's just sitting. So you can see there's a bunch of pressure throughout his entire bum and his thighs. The second picture is when he's tilted. And the third picture is when he's tilted, or so he's tilted partially. And on the third picture, he's tilted all the way back. So you can see between the second and third picture, there's a significant amount of pressure relief that happens in that last little bit of tilting. So very important that you tilt back all the way. There's nothing wrong with reclining if you're already in the tilted position. The problem with reclining, so if this is your power wheelchair here, this is your backrest, this is your seat. When you tilt, your whole body moves together. So there's no shearing. When you recline, just the back goes back. So you get shearing throughout your entire lower back and your bottom. So that's why I generally don't recommend reclining, and tilting is the much more preferred way of doing pressure relief. Does that make sense to everyone? Excellent. So in a manual chair, there's several different ways to do your pressure relief. The most efficient way is if you have the strength to just do a straight up push-up and hold it for 30 seconds. If you don't have the strength to do that, it's fine. You can lean forward for 30 seconds, then lean over to your right side for 30 seconds, and then lean over to your left side for 30 seconds. You need to make sure that you're in each position for at least 30 seconds. So it will be 90 seconds, a minute and a half in total of doing pressure relief every 15 to 20 minutes. And then if you're able to stand, similar to the push-up, you want to stand for at least 30 seconds. Just make sure that you're safe with standing and you're not going to fall.
Melissa, could I just interrupt for a moment? I'm just wondering, the way that we're viewing this, we see the next slide. Is there any way to make the slide that we're viewing a little bit larger to change the view?
Let me see.
If not, that's okay, but I just mentioned.
Maybe if someone else does the sharing for me.
You need to click on the display settings that you see on the top, and there should be an option which says swap. Yeah.
Ah, thank you. So your
Thank you.
proper positioning in the wheelchair, you want to be sitting upright. So if you're thinking back to like the 1800s etiquette rules, you want to be sitting like that. So you want to sit with a straight back, and you do want to have a little bit of tilt in your lower back, which is called an anterior pelvic tilt. You want your hips, knees, and feet to be at 90-degree angles, and your feet should be flat on the foot plate. And you want your shoulders to be relaxed in a nice neutral position. A lot of times, especially if you have like a neck level injury and you're using your accessory muscles to breathe, your shoulders start to come up like this. And that can actually put a lot of pressure on your shoulder blades when you're sitting in a wheelchair. So be aware of where your shoulders are when you're sitting in the chair. Typically, things that can cause poor posture in a wheelchair are the wheelchair backrest height and firmness. So this is more an issue in a manual wheelchair. So for example, if you generally use a custom wheelchair, but for whatever reason your custom wheelchair broke and you're now just using a standard wheelchair, those backrests are not firm at all. They're just fabric. And over time, they tend to get looser. So it will eventually loosen to the point where it puts you in what we call a posterior pelvic tilt. So instead of having that nice little curve in your lower back, instead you look like the person in the bottom picture here, where there's a lot of pressure on your tailbone. Your butt is or your tailbone's kind of pointing up to the ceiling, and there's a lot of pressure on your lower back as well. The wheelchair leg rest height is also a huge component to good posture in a wheelchair. If the leg rests are too short, your knees are going to be up toward your face, and it's going to put extra pressure on your sit bones. If your leg rests are too long, it's going to kind of pull you forward, and it's going to put you in that bottom posture where you have a lot of pressure on your tailbone and your lower back. And then cushions, even though cushions can be great, they can also exacerbate problems as well. So you want to make sure that the cushion is actually the cushion that has been recommended to you either by your therapist or the wheelchair clinic clinician. And also keeping in mind your own trunk control. So if you have really good trunk control and you're able to kind of scoot yourself back and reposition yourself easily, you're at less risk for getting pressure injuries. If you don't have great trunk control and you go over a bump when you're in your wheelchair and you kind of move to the side a little bit and aren't able to fix yourself, that's going to put increased pressure on your ribs and on your back. So that will put you at more risk for getting pressure injuries. So there are 1,000,001 different specialty cushions out there. So what I did is to make it easier for everyone, I broke it down into the different types of specialty cushions versus like the actual cushions themselves. So an air cushion, that'd be something like your Roho, which is a pretty standard cushion, especially if you're a new wheelchair user or you're in rehab. It's generally, at least at Spalding, that's our go-to. We put everyone on Rohos for the first little bit that they're there. And the reason we do that is because it is the gold standard for skin. However, a Roho is not the solution to all your problems because it can also facilitate horrible, horrible posture. And I've definitely had patients get pressure injuries from using a Roho because just the way that their body was shaped, the Roho wasn't doing it for them. And it put them in a position that made them at a higher risk for pressure injuries. So foam cushions, that's just like your basic foam. There's a very few pure foam cushions out there for spinal cord injuries. Most of the foam cushions are geared towards people who have orthopedic injuries and won't be in a wheelchair for an extended period of time. They're okay for the skin. I gave it a B. And they're okay for posture. They range from like super, super thin to like pretty thick. So the thicker it is, the better it would be for your skin and the better it would be for your posture. But again, foam is kind of neutral, middle of the road. Then you have gel. So gel is usually a combination of foam and gel. It's rarely, I don't think I know of any cushions that are just gel. So gel is good for the skin. It's neutral. I gave it a B, but it's really good for posture. So for people who don't have great trunk control, I usually recommend gel cushions because what it does is it creates a little pot for your bum to sit in. And that pot can actually help stabilize your trunk. So if you don't have great trunk control, that little pot can help stabilize you a little bit. So I gave it an A for posture. The one thing to think about with gel, and this is more so if you've had your cushion for like 10 plus years, which I really hope you haven't. The gel cushions that were made like 10 years ago were large gel cells, and the temperature outside had a big effect on how viscous the gel was. So people would oftentimes get pressure injuries in the winter and in the summer. In the winter, the gel got really hard. In the summer, it got really soft and it would just kind of splay out to the side. The newer gel cushions are not like that. They're very small individual cells, so you don't necessarily have to worry about that. But if you do have a cushion from like early 2000s, you do want to be aware of that. And then you have hybrid cushions. Your hybrid cushions are the most common cushions, and that's probably what you're using. And they're usually the best choice for skin and posture because you can do combinations of things. So you can do an air cushion with a foam like front. So it gives you that little pot, but it also gives you the air for your skin. So most cushions that we recommend are hybrid. So people are always asking me, where did my wound come from? And it's never 100%. You're never 100% sure where the wound came from, but more often than not, if you have a sacrum or coccyx wound, so your lower back or your tailbone, that's usually from your bed, unless you have really bad posture in your wheelchair. If it's on your sit bones, so your ischial tuberosities is another name for it, that's usually from a seating surface, so your shower chair, your car, or your wheelchair, generally. Sorry, I forgot to mention I have pictures. So moisture-associated skin damage. Most people who have a spinal cord injury will have moisture-associated skin damage at some point in their lives. And it can come from numerous amounts of things. So it can come from incontinence, it can come from sweating, it can come from like not drying off appropriately after a shower. What it is it's just a very superficial shearing of the skin. So it looks like very shiny skin. It's generally, if you press it, it will turn white, and it doesn't have induration. So induration is that like very firm, sometimes it feels like jelly skin. So it should not have that. It generally looks jagged, and the reason why it's jagged is because the skin has been wet. So it's like if you're in a tub or a shower or a pool for an extended period of time, your fingers and toes get really pruny. So your skin got really pruny, and then there was some shearing or friction force that literally pulled the skin apart. So that's why you have those irregular borders. And the most common area to get it is in your butt crack. So we call it a crack in the crack. So if you do have moisture-associated skin damage, what should you do? Make sure you're not wearing a brief in bed. If you need to wear a brief when you're up in the chair, that's fine. Just make sure that you're checking it and changing it frequently. If you are able to void on your own, then doing timed voiding. So most often we recommend voiding, so urinating, every 2 hours and trying to have a bowel movement once a day. Removing any wet clothes. So this is more an issue in the summer after people have gone swimming. Don't leave your bathing suit on. Change into dry clothes, even if in an hour you're anticipating on going swimming again. You don't want to be in those wet clothes for an extended period of time, especially if you're sitting in your wheelchair, because then that will make your wheelchair wet. And then even if you do put on dry clothes later, you're still getting the moisture from your wheelchair. And then make sure you're fully dry after taking a shower, especially your feet and your butt. Those are the two areas people tend to forget. So how do you know if you have a pressure injury or a moisture wound? And keep in mind that you can have both concurrently. If it's just a pressure injury, it will be a perfect oval or circular. The peri wound, which is the skin around the wound, might feel firm, or it might feel like jelly-like. It won't really feel like skin though. It's usually over a bony area, and it can get pretty deep. If you have a moisture wound, it's usually a thin slit, and it's usually the crack in the crack. It's uneven looking, and it's very superficial. So it can be confused with a stage 2, because stage 2s are very superficial. The difference is the edges of moisture wound will be jagged. A stage 2 will be a pretty circle or an oval. And then usually if you have moisture issues, the skin around the wound, so the peri-wound skin, will be red as well. So we talked about how to avoid moisture wounds. We talked about how to avoid pressure injuries in a wheelchair. How do you avoid pressure injuries in bed? So for those of you who have gone through Spalding, I'm sure you all know and love the quantum tilt. So the quantum tilt is a half back, half side lying position. You're kind of at a 45-degree angle, and it mostly reduces the pressure at your lower back and your tailbone, so your sacrum and your coccyx, and you have no pressure on your ischial tuberosities or your sit bones. Regardless of what position you sleep in, you should change position every 2 hours. Now, that's what we tell people. I understand in real life that doesn't happen. But if you do have a wound, you should try and get as close to every 2 hours as you can. When we have people who are newly injured at Spalding, the nurses help them turn every 2 hours. Generally, by the time they go home, they can push it to like 3-4 hours because your skin does develop some toughness if you're lying in the same spot all the time. But if you have a wound or if you are newly injured, it should be every 2 hours. And then for those of you who work with people who have spinal cord injuries or need repositioning at night, you roll someone fully onto their side. You place 2 or 3 or 1 or 2 pillows behind their back, but you want to make sure it's above the lower back. And then you place 2 or 3 pillows under the top leg. And then you go to their other side and you just scoop the sheet a little bit and make sure they're comfy. And it should end up being a very comfy position. You shouldn't feel extra pressure on your shoulders. You should feel like you can breathe easily and you shouldn't feel any pain. The only body part that you should be concerned about in this position is the hip that you're lying on. So if you have very bony hips, that's something to keep in mind. You can also do side lying. So this decreases the pressure on your lower back and your tailbone even more. There's still no pressure on your sit bones, but it does put more pressure on your hip and your greater trochanter, which is like that little nubby area just below your hip. You again want to change position every 2 hours. This position tends to be really uncomfortable on shoulders, especially if you have a cervical level spinal cord injury or if you have any sort of subluxation in your shoulders. Heels are a very common place to get skin breakdown. So you want to be aware of where your feet are at all times. So like I had mentioned before, when you're sitting in a wheelchair, you want your feet flat on the foot plate and you want to be wearing shoes. You shouldn't be in your wheelchair without shoes for an extended period of time. When you're in your bed, you should float your heels. So there's 1,000,001 different ways to float your heels. You can do something as simple as putting a pillow underneath your legs, or you can have fancy pants boots. We tend to use the fancy pants boots at the hospital. So you do want to do your skin inspections, and you do want to do skin inspections. Even if you don't have a wound, I always recommend do it twice a day when you wake up and when you go to bed. You want to really check any area where you don't have normal sensation, where you've had wounds before, or if you've had any surgery in that area. So to do your skin inspection, you want to make sure you have a good light or who's ever assisting you has a good light. You want to touch, see, and smell, and occasionally listen, which I know sounds weird, but I'll get to that. So you're looking any area that doesn't have normal sensation. Always look on your heels, between your toes and the bottom of your feet. It's very common to get a fungal rash on your feet, and those fungal rashes, if they're not treated, can get real gnarly and can cause a lot of infections. And also look under any braces or orthotics that you wear. So if you're wearing a neck collar, your chin is a big place to get breakdown. If you have AFOs, check your ankles, check your heels, and the sides of your feet. You want to feel for any swelling, or if your feet or legs feel any warmer than they typically do. Generally, if there's increased swelling and warmth, that's a sign that there's something brewing. You want to smell if there's a smell. If you do have an open area, if it smells different, that's also concerning for infection. And then listen. So if you have a wound and you touch your skin and it sounds like Rice Krispies, go to the ED immediately. That is a very, 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 very concerning infection that can kill you within hours. So very uncommon. But if you do notice that, please go to the ED immediately. So you're looking for anything that looks weird. Bruises, wrinkles, abrasions, blisters, bleeding, and then any changes in moles. You want to check your feet for blisters, cracks, dry skin, fungal infections, or bleeding. So no matter what your skin color is, you know what your skin's normal is, and anything that is not your normal, you want to get checked out. So now my favorite part. What can physical therapy do to help your wounds? So we can help improve blood flow to the damaged area, improve muscle bulk, improve posture, help with seating, help with mattresses, and then obviously we provide a lot of education. So to improve blood flow, 2 ways that you can do this. Pressure relief, we already talked about that. When you sit on a surface, your vessels get squished. When you do pressure relief, the vessels open and you get more blood flow to the area. The more blood flow you get to the area, the better, which is why electrical stimulation can be such an effective modality to use to help prevent and treat pressure injuries. So what electrical stimulation does is it contracts a muscle. Now, the unfortunate thing is it only works if you have an upper motor neuron injury. So generally, people who have a T6 and above injury will get a contraction from this little device. Between T6 and T10, some people do, some people don't. Generally, if you have an injury below T10, it's considered a lower motor neuron injury and you won't get a contraction. So eStim might not be an effective tool for you. But if you are able to get a contraction from eStim, it can significantly reduce your risk for getting pressure injury and improve healing time if you do have one. This is what I did my research on when I was working inpatient at Spalding. And I found that for the people who were able to use eStim, their wounds healed 74% faster. And this was all stages, 1 through deep tissue injury, than people who were not able to use it. So eStim can be a very, very effective modality. And then as PTs and OTs, we can help you figure out what mattress will be best for you at home. So some people have hospital mattresses at home and it works for them and they're happy with that, and that's great. If you're not interested in a hospital bed, either insurance doesn't cover it or you want to sleep in the same bed as your partner, there are several other mattresses out there. You will have to private pay for it, but there are mattresses that are safe for you to sleep on. I generally do not recommend an inner spring because each of the coils within an inner spring are pressure sources. So generally don't recommend inner spring mattresses. If finances are a concern for you and you already have an inner spring mattress, then generally I recommend getting a memory foam overlay and putting that over your inner spring mattress. Memory foam is a great option for pressure relief, especially if you get like the really thick memory foam mattresses, like your Sleep Number mattresses. The downside of the memory foam mattresses is that it retains heat. So if you get really sweaty, it can cause problems because then you're at risk for moisture associated skin damage. And it also forms to your body. So if you already have trouble with bed mobility, it can sometimes make bed mobility a little bit more challenging. That being said, there are beds out there like Sleep Number where you can change the firmness of the mattress. So I've had a lot of people go home with Sleep Number mattresses and they love it because when they're sleeping, it can be nice and soft and it forms to their body. But then when they have to get up to do their ADLs, they can make it firm and it helps with their mobility as well as their transfers. So air mattresses, they're great for pressure relief. They're really hard to move on though. So like your typical alternating pressure mattress that you get from the hospital, great for pressure relief, really, really hard for any sort of mobility or transfers. And then water beds. So every once in a while I get a question about a water bed. They're the best for pressure relief. It's like the Clinitron or the Envela mattresses or beds, sorry. But they're impossible to move on. Even without having a spinal cord injury, it's very hard to move on. Plus they pop, and that's a problem. And that is my presentation.
Thank you. Thank you
Awesome.
so much, Melissa and Dr. Sue. That was, wow, a lot of fantastic information. Why don't we go to the chat right now? If anyone has questions, I'm encouraged, everybody will do our best to field as many questions as we can. Let's see.
Can I
So
just
in
say
the
one thing about pressure injuries before we
please,
take questions?
please.
So with pressure injuries, stage 1 and deep tissue injuries present very differently in lighter skin versus darker skin. So if you have darker skin, you might not get that blanching that we were talking about. So just be aware of what your normal skin looks like. And if you notice any changes, usually it's darkening of your normal skin color. That's something to be concerned about. With a stage 1, it will just be that darkening of your skin color. If you have a deep tissue injury, it will be that darkening of your skin color, but it will also feel different than your skin normally does. All the other stages, the inside of everyone's body looks the same. So that would be the same whether you have light or dark skin.
Thanks for that clarification. Okay, so I'm just going to kind of go through the chat and Melissa, Dr. Sue, please feel free to answer whichever question you'd like to. Ellen is asking, how effective is hyperbaric oxygen treatment? If stage 4, will surgery ultimately heal pressure ulcer and chronic infection? Are there any other alternatives? So we've got kind of got 2 questions there.
Hyperbaric oxygen, a stage 4, I don't think it's going to help a lot. I don't have, there was some older research that was done. Now they have VACs. I don't think they use hyperbaric a lot. Melissa, correct me if I'm wrong.
So the tricky thing with the hyperbaric oxygen is you need good blood flow going to the area because oxygen gets transported through your blood. So if you don't have good blood flow, you can have all of the oxygen in your blood, but if it's not getting to the damaged area, it's not going to help you.
Right. And that kind of leads into the question about, is surgery your only option for a stage 4? It's probably the best option. Sometimes with a VAC and really meticulous attention to making sure that there are no sinus tracts and that the wound bed is clean, and that it heals from the inside out, not that it heals just from the outside with a big hole underneath. Sometimes, rare. Most of the time with a 4, you're gonna need a flap. And the reason for that is kind of what Melissa was saying, that you need really good blood flow, and bone on its own doesn't have great blood flow. So it's really vulnerable, to infection. And the other thing that I forgot to say when I was, doing the presentation is this. If you have a deep infection, especially a bone infection, whatever you're growing in there is probably not whatever's growing on the surface of the wound bed. So if they get a culture, at the bedside, they're telling you more about like kind of what's in the air than much of anything else. If you've got a bone infection, what they really have to do is go to the operating room and remove any dead skin tissue. And if there is bone, to actually get a little biopsy and send it for direct culture, both aerobic, where it tolerates oxygen, and anaerobic, where oxygen kills it. Let's see, there's a question here. What is a Dakin? It's Dakins, it's a proper name, DAKIN''S, and it's essentially a bleach solution. And they use it like a quarter strength. And I don't think they pour Clorox into a beaker or anything. But that it helps a little bit with a really icky sore. Truthfully, I think normal saline is a better choice.
The problem, sorry.
Sorry.
The
we're
problem with
so-
Dickens is it kills healthy tissue. So if you have any healthy tissue, you're killing that as well as the not healthy tissue. So it's generally now only recommended if you have like real gross dead stuff going on in there.
Yeah.
Let's see.
We've got a question, and then Jerry, I see your hand up. Got a couple about cushions. How often should cushions be replaced?
So that's going to be different for different people. Anytime you have something new medically going on, so say you had your spinal cord injury 15 years ago, and then you need a new surgery. And because of that new surgery, you have decreased mobility, even if it's just for a little bit, that would be a reason to have your cushion changed. I believe, depending on your insurance, it can be changed between any 1 and 5 years. Every insurance company is slightly different. Anytime you have the ability to get a new cushion, I would recommend getting a new cushion. Even if it's the exact same cushion, it always helps to have extras. You can use that extra cushion on an airplane. You can use it in your car. You can use it if you want to sit on a bench. So there's just many good reasons to have multiple cushions available to you. And then even if it's different types of cushions, you might want different cushions for different sort of settings. So if you might want a different cushion if you're sitting on a cushion in your car or an airplane versus if you're sitting in your wheelchair. So those are things to take into consideration with how often cushions should be replaced. Unfortunately, just like everything else, it's very vague. And it's truly because every insurance is different. But anytime you have a new medical issue that reduces your mobility, you should get a new cushion.
We're going to stick with the cushion questions. We have any opinion or experience regarding, is it Vicare O2 cushions? Which one?
I have not had experience with Vicare cushions. I don't know if they've made their way to Spalding yet. I've been per diem at Spalding for the past year, so I haven't been there consistently. But I can ask around and see what other opinions are on the Vicare cushions. And then I see there's one for a suggestion for brand for hybrid cushions. And that's similar to my first response. Everyone's so different that there's not a bad cushion or a good cushion in general. There might be bad and good cushions for you, but the cushion that's good for you might be bad for me. So there's not really a good answer to that. When you're thinking about a hybrid cushion, you want to take into account how sweaty are you? What is your trunk control? And how's your skin? Those are the 3 things that I would focus on when you're looking for a hybrid cushion.
Thank you. Jerry, go ahead.
Yeah, it's great seeing Melissa again. I had a couple of points. Also, to get a seat cushion cover. It's always good to have a spare. I always have a spare cushion that's ready to go in case something happens to the one I'm sitting on. But what we have that's very valuable now is the portal. I found out that I had a little pressure wound on my left cheek, and I didn't think it was that bad. But my daughter, that's my PCA, said, I don't like that, Dad. I'm going to send a picture on the portal. And then within a couple of days, I had the visiting nurse come out. So I went through the process of having the visiting nurse come out, changing the bandage, and she said, it's just not closing right. And she called up her supervisor who ordered Meta Honey. And I think your husband David mentioned that a while ago. This Meta Honey, by the time she came back, it had closed the wound. So it's very valuable. And so that's the 2 things I want to get across is the portal and the Meta Honey. And Melissa, maybe you can help me because I know like Tatiana, Joe, and Patrick, I don't want them to get hurt falling out of their wheelchairs laughing at my Boston accent, which they always seem to do. But that's it for me.
Thank you, Jerry. Good points. And I just want to mention, if you cannot utilize the chat or use the hand raise feature, please just call out. Don't want to miss anybody's questions. I think the next we had Ryan asked for the eStim, which is better, TENS or EMS?
So TENS should not cause a contraction. So the EMS is better. TENS is good if you have pain. So most EMS machines will have a TENS setting. So I would say EMS for prevention and helping to heal a wound, but TENS if you have pain. The one thing that I didn't mention in my presentation is if you have an active infection in your wound, don't use E-stim because it can, in theory, spread the infection.
Mhm. Thank you. Matthew's asking if you could talk about the placement of stim pads for the various stages.
That's a great question. And unfortunately, just like many of my other answers, it depends, which I know is everyone's least favorite answer. So if you have not had a flap and you have a butt wound, generally, if you put the pads parallel to each other on a butt cheek, so either parallel vertically or parallel horizontally, that's generally how you get the best muscle contraction. And if the wound is in between, that's fine. But you don't want to put the pads on the wound. If you're looking up research about E-stim and wound healing, you might find E-stim in the actual wound. That's not what I'm talking about. This is totally different. The wound care or the E-stim I'm talking about is just getting a muscle contraction. So to do that, it's usually parallel vertically or horizontally, and the wound can be in between. That's fine. The goal is to just get your muscles pumping to get more blood flow to the area.
Thank you. Donna was mentioning that she uses a motionless waterbed with a memory foam topping. Heated waterbed keeps her warm in the winter, shuts off the heat in the summer, keeps her
I
cool.
love water beds. They're great. The one disadvantage is that they're very heavy. So if you're going to use one, you want to make sure, maybe have a structural engineer even come out and take a peek at your house to make sure you can support it, because you definitely don't want it crashing through the floor.
And most apartment places don't allow them either.
Mm.
Yeah. It's a shame because they're great.
Jessica's asking, does anyone know if silicone adhesive sacral foam dressings are covered by insurance as a preventative method with a stage 1 or MASD?
So unfortunately, insurances are generally not preventative. And oftentimes preventative dressings are not covered. That being said, there might be a few insurances out there that would do that. And it would take a lot of work from either your primary care, your physiatrist, who's ever recommending that for you, that have to write a letter. But even with that, the likelihood of it getting covered is pretty low.
Also, I wonder if, depending on the placement, if the dressing is going to make the area more moist, and it's a moist area to begin with, it may actually be counterproductive. I don't know how you feel, Melissa, but that's
Yeah, it depends on exactly what you said. It depends on where and what type of injury you have. If you have a complete injury and you don't sweat and it's on like your back, below your level of injury, it might be fine. I generally don't recommend it on tailbones or lower backs because the risk of incontinence is high, especially initially. And if you get pure poop in a dressing and you don't realize it and it sits on your skin, you can actually get burns from that. So we very rarely at Spalding did preventative dressings unless it was a very frail person or a kiddo.
Thank you. Before I go to this next question, I just want to ask, is there anybody here that has a question that isn't able to utilize the chat or the raise hand function? Please give a shout out.
Yeah, Jim, maybe Jim Clear here in Worcester.
Yeah.
Just thank you. A lot of information here, kind of overwhelming. I was tearing up in the very beginning how much there is and how complicated your system is, the body and spinal cord. This will be recorded so we can see it again, right? It's
Mhm.
for me to see it multiple times. And a lot of questions, I guess. I don't know where to start. I mean, probably can't answer them here. But dermatologist, you don't see for this shit. All through your primary care, if you have a problem, primary care, or start with a nurse, or you start having a problem.
So
Yeah.
go for it.
Go.
It really depends on who your care team is. I would say a physiatrist, if you have one, would probably be your best vet because they know spinal cord injuries. Primary cares, it's not necessarily in their training. And I know this just because I'm currently training to be a primary care nurse practitioner, and it's not anywhere in our training. Whereas I know with physiatry, they're very well versed in pressure injuries. So I would say physiatry, if you
Yeah.
have a wound that you're not necessarily concerned about, if there's a wound you're concerned is infected, or you're for whatever reason very concerned about it, I would go to urgent care or the ED.
Mattresses, basic mattress I was sent home with last summer is probably what, fine, I don't even know what it is, and I considering better mattresses. This might be getting too specific. What is the next step up from a regular covered hospital bed?
Usually, if it's just a standard foam mattress, the next step up would be an alternating pressure mattress.
Yeah, okay. And approach a physiatrist for that.
Mm-hmm.
Okay.
Yep.
A lot of learning here. Thank you very much. It's been excellent. Looking forward to reviewing it again.
Thanks, Jim. Thank you. Nana's asking, I heard Melissa did some specialty research with using eSTEM applications for pressure injuries. Do you have any links to journal articles related to this? I would like to read them to discuss them with my doctor.
Mm.
So the research I did was probably around 2020. So the articles that I have are probably a little old, but I can definitely share them with Heidi, and then she can share them with the group.
Yeah, and Nana, I'm not sure what your name is. So if you do want to also give me that information so I could contact you, that would be helpful. Thank you. Karen was asking about what is MediHoney. I just put a link to MediHoney, but do you want to say, anyone want to say anything about, I know it's a.
It's been used since the Egyptian and Greek times. It's tried and true, but it is not the solution for everything. There's not one dressing or ointment that is a solution to everything. So keep that in mind.
Great, thanks. I just want to make sure I'm not missing. And if I've missed anything in the chat, please let me know. Donna mentioned that she finds alternating between two different cushions is helpful. One for a couple of days, then switch to the other style.
And there were things about taking pictures or taking videos of skin, which I think
Thank you,
is a
yes.
really good idea. You know, if you, you know, if the angle's wrong for a mirror. And yes, serial photos will definitely tell you quite a bit.
Caitlin says her experience has been urgent care and even ER is not knowledgeable about SCI. Whenever she has the start of a skin issue, she goes directly to her wound clinic.
If you have a wound clinic to go to, I agree. That's definitely your best bet. If you don't, the easiest way to get into a wound clinic is either through your physiatrist or through the ED.
If you have VNA, you can ask if there's a wound care nurse on staff and see if you can get a visit from the wound care nurse. But again, you have to be careful about pressure relief, and you don't want it to, you know, sit. I agree that the trouble with the ED and the urgent care, besides not knowing about SCI, is that, especially with the way things are now, there's a very long wait before you see somebody. And if you have someone who's had a heart attack, they're going to jump the line ahead of you. So you are sometimes at risk for laying on a gurney for, you know, I don't know, umpteen hours. But I would definitely put in a call. I hope everybody here, if you have access to a physiatrist, start a relationship with one. If you don't like the first one, go to another until you find somebody that you feel comfortable with, because there aren't that many, unless someone who's in primary care has trained in a place that has a spinal cord injury model system. They have zero experience. Maybe there was one lecture about it in first or second year, maybe. But to their credit, they know a lot about a lot of things, and they're generally willing to learn more, they're willing to help, and they're willing to reach out. You really need a team of people, not just one.
Thank you. What other questions do people have?
Is that E-stim a home remedy that people use, or all under professional or inpatient? Or
It can be anything. It's something that you have to be trained on, or a caregiver can be trained, but it's not rocket science. So usually it's a physical therapist ordering it for you, but an occupational therapist could order it too. So if you had home PT or OT, they could order it for you. I'm sure a physiatrist could order it for you as well. And it, in the realm of things, it's not super expensive. The last time I checked, it was like $300 to get a good machine. You can get just a TENS machine at CVS. But like I was saying with Ryan's question, TENS is good for pain. It's not good for contracting muscles. So I'm sure your physiatrist could order for you PT, OT, and then they could train either you or a caregiver how to use it.
And that's preventative or after there's a start of a wound? That's
Both.
really okay.
Because what E-stim does is it brings more blood flow to an area. So that helps prevent wounds. It can also help build up bulk, muscle bulk. So like if you do it on your butt every day, your butt cheeks are going to get bigger. Not extensively. You're not going to look like a Kardashian, but it will help bulk you up, which gives you more padding. So it can be preventative in that way as well. And then when you have a wound, because it is bringing more blood flow to the area, it can help heal it faster.
Have you ever had situations with people having breakdown and also having psoriasis or a psoriasis?
Yeah, so having psoriasis can put you at higher risk because your skin is already breaking down. So like if you have psoriasis on your butt, or any of those like areas where you're at higher risk for getting pressure injuries, yeah, it's especially if you're having a flare, definitely puts you at more risk.
Yeah, and then the treatment, it's like it's the stage 1, stage 2 fissuring.
So it's when you have eczema or psoriasis or any other pre-existing skin condition, it's really hard to tell the difference between the skin condition and the stage 1. So you just need to be super, super careful, and talk to whoever prescribes your psoriasis medication. They might need to change it so you don't have flares as frequently.
Yeah, I've been doing this for 30 years. Yeah. Thank you.
Thank you. Pam asked, sorry, any downsides to using EMS as prophylactic?
If you have an open as a prophylaxis, no, not really. There is a potential to get burns from it if you don't use it properly. But in all of the 15 years I've been at Spalding, I think that's only ever happened once to a patient. And it was his brother hadn't been trained on how to use the E-stim. So the patient was trying to walk him through it, and it didn't work out in his favor. But that was the one time it happened. So no, very like less than 1% risk of doing it prophylactically.
Thank you. We have just a couple of minutes to go. Dr. Bergman put in the chat, the name of the cream is Sarna, S-A-R-N-A. Thank you for adding that. Donna's mentioning opiates can cause itchy face and head, another reason to avoid if possible. Do we have any other final questions from the group? Anyone maybe who hasn't had an opportunity to ask a question?
I got one more brief one if I can keep. All the videos we saw at Spalding, I missed a lot of them. Are they available off a portal somewhere before you leave, modifying a house? All there were dozens of videos that were available.
It's a good question. I'm not actually sure of that answer. I know it's on like
In-house,
on repeat on the TVs in Spalding, but I'm not sure where it's stored.
I'd be curious. Okay, probably unrelated.
Well, oh, go
Sorry,
ahead.
yeah, just the presenters, do you mind if you share your presentations with the group? So I think there's a lot of links and stuff in there that would be great for everyone.
Sure. How do I do that?
We can talk. I'll email you.
Okay.
Yeah, and if there's anybody who would like information about the presentation, because it is difficult, I don't have everybody that's on here, I may not have your email addresses. If you are interested in it, please just reach out to me and let me know, and I'll make sure that I get back to you. I'm Heidi at SCIboston.org, so just reach out if there's information that you would like. Mary,
Hey, just really quickly, I know when you have a serious injury, pressure injury, like, should you be getting up in your chair? And if you are, how long can you get in there? Is there a limit, like 5 minutes or 2 hours or 10 hours? I mean, what is?
That's a really good question. And it depends on where your sore is and what your chair is like. The kind of party line used to be absolutely not. But let's say that your sore is on the tip of your sacrum, and you have a chair where you've got better posture, and you know, you're not putting extra pressure on it. You could. I would start with maybe 15 minutes and check your skin. And then you can go up from there in 15-minute increments. But I think you want to be mostly, mostly with pressure relieved.
I guess I could add something. It's Steve. Can I talk?
Joe, go ahead.
Sue, you maybe remember me from a long time ago. Steve Duquette's at
Sure.
University Hospital from
I
Story. Hi. I've had so many deep pressure stage 4 wounds with osteomyelitis, and it's so difficult to get treated soon enough. When you see a stage 2, quickly gets to a stage 3 and then 4. There's really no coming back without plastic surgery. It's probably the only thing that's helped me. I just want to help anybody else that's listening. If they have any questions. I've been through an awful lot, and now I've even moved up to prosthetic shoulder stuff. So it's been a tough ride for 34 years. But those pressure wounds for people with spinal cord injuries, paraplegics like myself, really got to be careful. There's now air loss mattresses. I just upgraded to that. I think that's going to be very helpful. We'll see. I can't afford another one of these stage 4s. So advice to everybody, take care of yourself as much as you can.
Okay.
Low air loss is a great idea. There are some mattresses that combine low air loss and alternating pressure.
That's right. I have an alternating pressure one. It's great.
Good.
Good luck to everybody.
And you, I'm happy to, have you touch base with me. Heidi's got my information.
Okay, yeah, I'll do that.
Okay.
Great to see you.
Good to see you.
And Heidi and everyone.
Yeah.
I haven't met
happy to see
Melissa. I don't get to go to Spalding. I'm sorry, but I tried, but I never get to go.
And you found
All right.
Yeah,
I want to just watch the time here. Thank you so much. Thank you all for attending. Melissa, Dr. Sue, thank you again for sharing all this incredible information with us. Yes, prevention, right? Some of the best advice, but certainly lots of good strategies for when there are wounds, for healing them and for dealing with it. So really appreciate that. Again, if anyone has questions or needs more information, please reach out to me. Heidi at SCIboston.org. Of course, you can reach out to anyone on the team. Diane, Jess, looking on the screen here. Yeah, and happy to help you in any way that we can. So hope you all have a great day. and remember to do some pressure reliefs. I noticed a few people I noticed Eileen during it. I was like, oh. Just as Melissa was talking about it, I saw Eileen go up and down. Yeah.
Yeah.
All right. Thank you.
Thank you, Heidi.
Take
Thank
care,
you.
everybody.
Thank you, Doc.
Thank you all, folks.
Great
Thank you,
session.
Melissa. Thank you, Doc.
Thanks.
Take care.
Thank you very much.
Great day.
Outstanding.
Thank you for everything.